Absolutely. So with the imaging, and we actually did mention those earlier, which imaging that you like to get. So I guess on the specific images, say starting with the AP, what are you actually looking for on those images?
Yeah, so the AP radiograph, I think you definitely need to get a standing radiograph. I like to get bilateral knees on one plate. You'll definitely see it where you may have an X-ray that's not weight bearing, and then you go back and get a weight bearing X-ray, and it's just bone on bone on bone. The deformity is exaggerated even more, and so I think you definitely need that weight bearing film. From the AP, you can kind of see how much wear there is, what their deformity is. If it's a bilateral wear pattern, you could think of some type of autoimmune. If they've had any implants in place, if they've had a tibial tubercle osteotomy with screws in place, those are things you have to think about. If they had an ACL
Yeah.
reconstruction, the hardware may be in your way, and you need to know that so you can have the appropriate hardware in the room for you.
Hmm. Okay. And awesome. So yeah, that's always a good thing to keep in mind. I know Cody, he's a sports guy. So yeah, that's I haven't seen many cases like that, but yeah, I could definitely see how that would change your whole operative planning if there's all these previous hardware in there from a ACL repair or something like that. So definitely good to keep in mind. So this is actually going pretty well because we talked about some of the imaging. I guess just specifically, anything in particular you're looking for on lateral radiographs?
Yeah, so so one more thing. When I'm in the room, there's a couple other things you can do with radiographs. So I like to use the Cobb angle tool. You'll have these x-rays up in your room. I draw a line that's straight down the anatomic axis of the tibia and perpendicular, so you can kind of see where your tibial cut lines up. That
Yeah.
also lets you kind of know how much you're taking on the medial and lateral side. And then same thing with the femoral alignment. I'll draw a line down the axis of the femur and 6 degrees off from that to get the mechanical axis. So I'll use the radiographs in the operating room as well. But so on the lateral radiograph specifically, you're looking for osteophytes, especially like a posterior osteophyte. That can mean that the tibia is subluxing anteriorly. So let's say you're thinking maybe, oh, this may be a good candidate for uni, but you see a big posterior osteophyte with medial wear pattern. You may think twice about putting a uni in that patient because that could be a sign that their ACL is deficient.
Mhm.
So you want to know that. You also want to look at what their native tibial slope is. I try to match that. It can be fairly variable for that. And then the other important thing to look at, especially if they've had prior surgeries, you want to make sure that they don't have a patella baja going on. You know that if you see a patella baja in a lateral x-ray, your exposure is going to be a lot more difficult. So you may need to think about doing something like a quad snip or some type of procedure to kind of further facilitate exposure of the knee, and then it may just not be a straightforward home run case.
I like that. So we're saying things to, I want to touch on the lateral, and then I actually kind of want to go back to the AP and dive into that a little bit more. So we're saying on our lateral film, of course, we want to be on the lookout for where our patella is, our patella height. If we're doing patella baja, you're thinking it may be a little bit, you may think earlier that you may need to utilize some other techniques in order to evert the patella after you do your, parapatellar arthrotomy. Another thing to look for is on the tibial side is look for any posterior wear, which may indicate that you have an ACL deficient knee due to possible chronic subluxation of that tibia. Um, and then you also want to look at your slope, and you want to try to match the either native alignment, or you want to try to figure out what cut you'll have to do in order to make your slope, I guess, may depend on the implant that you're using, but the ideal slope for that implant, is that all correct?
Yeah, I agree with that. Different implants require a different slope. For example, like a rotating platform type implant, the recommendation is to actually cut the slope at neutral. But for other type of implants, you kind of want to match the tibial slope. So I think all those things you said are important.